I'm Dr. Felix Tyndall, neurologist, and this video module is about how the brain controls eye movements. Specifically, we're going to talk about horizontal gaze control and internuclear ophthalmoplegia. Just know that vertical gaze uses the same structures and rules, but horizontal gaze is easier to describe. I have nothing to disclose. The learning objectives are: 1. Describe how horizontal gaze is controlled by the brain. 2. Recognize the localizing value of gaze palsy and gaze deviation in stroke. And 3. Recognize the clinical signs of internuclear ophthalmoplegia, its localization, and the common causes. This picture is the final common pathway of eye movements, comprised of cranial nerves 3, 4, and 6, the neuromuscular junctions, and the extraocular muscles. But we are concentrating on what happens within the brain before we get here. Like other parts of the central nervous system, the central nervous system visual pathway is organized into afferent and efferent sides, or sensory and motor. In this case, the sensory input is light, and the motor output is eye movements. We need eye movements to get and keep an image on the fovea, which has the greatest concentration of photoreceptors in the retina. There are a number of types of eye movements, and we will mention several here. One is saccades, which are those quick eye movements that change what you're looking at, that move the eyes from one point to another. Smooth pursuit, to track an object and keep it on the fovea. And the vestibulo-ocular reflex, to keep the eyes still when the head moves. You will hear about that in the vestibular system module. All of these eye movements are conjugate. The eyes move together in sync. This is a sagittal view of the brain in which I've put nothing in it yet to illustrate 5 things regarding the control of eye movements. Light enters the eye and reaches the occipital lobe, the visual cortex here. And it sends that information to other parts of the brain to process. For example, there is an area that combines the occipital lobe, the parietal lobe, and the temporal lobe. It's the parieto-occipital-temporal junction, POT. And that analyzes what we should look at from among competing objects in our environment. And it sends that information ahead to the frontal lobe, to the frontal eye field in the frontal cortex. That makes our voluntary decision about moving the eyes to a point we want to look at. And that in turn sends a signal to the brainstem. First, to the midbrain for vertical eye movements, and to the pons for horizontal eye movements. This is a close-up sagittal view of the midbrain and the pons. Those green ovals represent vertical gaze centers in the midbrain that have received those signals from the frontal eye fields and tell the 3rd and 4th cranial nerves to move the eyes up and down. At the bottom is the equivalent green oval for the horizontal gaze center, which tells the 6th cranial nerve nucleus to move the eyes horizontally. And in between that blue line is a white matter fiber tract along both sides of the midline in the brainstem, the medial longitudinal fasciculus, connecting the 6th cranial nerve nucleus to the 3rd cranial nerve nucleus to yoke the eye movements together to produce conjugate eye movements horizontally, which you'll see momentarily. So, the brain controls gaze in this way. Each cerebral hemisphere controls conjugate gaze to the opposite or contralateral side. For example, the right hemisphere controls conjugate gaze towards the left side. There's one small exception, which is pursuit, which is ipsilateral or same side, but has little practical use, so we'll leave that. And each side of the pons controls conjugate saccades to the same side. The left pons controls conjugate gaze towards the left, and the right controls conjugate gaze towards the right. So how do conjugate eye movements occur? When we look to the left, we contract the left lateral rectus muscle and the right medial rectus muscle at the same time. So how does this happen? First of all, we have a coronal section of the brain and two eyes facing you, and you're facing them in this diagram, which we'll use again later on as well. So the blue dot at the top left of the screen, which is the right side of the brain, is the right frontal eye field. That sends the command to look to the left. It sends that signal down through the internal capsule to the brainstem, where it crosses the midline to reach the left horizontal gaze center in the pons. And that talks to the left sixth cranial nerve nucleus that has two parts: a motor neuron, which controls the left sixth cranial nerve and left lateral rectus muscle to abduct the left eye. And now we need the right eye to adduct at the same time. It is yoked to that movement to be a conjugate leftward movement by the interneurons in the sixth nerve nucleus, which send their fibers up the right medial longitudinal fasciculus to the right third nerve nucleus, to the right third nerve and the right medial rectus muscle, like this. And that way we have conjugate gaze to the left. So the summary, the short form of this is that the right frontal eye field tells the brainstem to turn the eyes to the left, or the left frontal eye field tells the brainstem to turn the eyes to the right, and the connection to yoke the eyes together to create conjugate synchronous eye movements is the medial longitudinal fasciculus between the sixth cranial nerve nucleus and the third cranial nerve nucleus in the midbrain on the other side. What happens when things go wrong? We get abnormal eye movements. And the symptoms and signs of those abnormal eye movements are gaze palsies, which do not produce any visual symptoms, such as no diplopia, but you can see them when you look at the patient because the eyes cannot move in a particular direction. Diplopia can be caused by some lesions of the brainstem, as we'll see, and also by lesions of the third, fourth, and sixth cranial nerves, the neuromuscular junctions of the extraocular muscles, and the extraocular muscles themselves. As well, there can be nystagmus, rapid involuntary back and forth movements of the eyes causing blurred vision or oscillopsia, in which a still object looks as if it is moving. Let's consider 3 lesions. 1, a frontal lobe stroke affecting the frontal eye field. 2, a pontine stroke affecting the horizontal gaze center, the sixth nerve nucleus, or both. And 3, a lesion of the medial longitudinal fasciculus. Consider a right frontal middle cerebral artery territory stroke affecting the frontal eye field and causing a left hemiparesis. Remember that the corticospinal tract crosses below this at the medulla. We learned that the right frontal lobe controls horizontal gaze to the opposite or contralateral side, so the eyes cannot look to the left. And they will be deviated to the right, that is, towards the lesion and away from the hemiparesis. Here's an example. You have an axial CT scan of the brain, and that black area with the white arrow in it is a right frontal lobe infarct affecting the right frontal eye field. So the eyes cannot look left, and they're deviated to the right, and it affects the motor cortex, so there is a left hemiparesis. Here's our diagram again. You have a right frontal lobe lesion causing left horizontal gaze palsy and gaze deviation to the right. So we said that, so the right frontal eye field sends its signal down through the internal capsule to the brain stem, crosses the midline to the left horizontal gaze center, which in turn talks to the left sixth cranial nerve nucleus. The motor neurons send their signal to the left sixth cranial nerve and left lateral rectus muscle to abduct the eye, and the interneurons cross the midline in the medial longitudinal fasciculus up to the third cranial nerve nucleus in the midbrain, which controls the right third cranial nerve and right medial rectus muscle to adduct the eye. But in this case, it cannot do that. We have a lesion in the right frontal eye field, and as a result, all those steps cannot occur. Therefore, the left frontal eye field signals are unopposed, so the eyes are deviated to the right. Consider a right pontine stroke affecting the horizontal gaze center, the sixth cranial nerve nucleus, or both, and causing left hemiparesis, since it is still above the decussation of the corticospinal tract. We said the right pons controls horizontal gaze towards the same side, so the eyes cannot look to the right, and they will be deviated to the left. That is, deviated away from the side of the lesion and towards the hemiparesis. Here's an example. We have an axial CT scan of the brain showing the posterior fossa, the brain stem and the cerebellum. And that white area just to the right of the midline in the pons is blood. And the arrow points to a right pontine hemorrhage, which has caused a right horizontal gaze palsy and left hemiparesis. Once again, our coronal section of the brain diagram and the eyes. And in this case, what was supposed to happen was the left frontal eye field was supposed to come down, signal the right horizontal gaze center, the right sixth nerve nucleus, the right sixth cranial nerve, and lateral rectus muscle, and via the medial longitudinal fasciculus, the left third cranial nerve nucleus, left third cranial nerve, and left medial rectus muscle to move the eyes to the right. But in this case, we have a lesion in the right pons, so the eyes cannot pull to the right, and the unopposed signal from the right frontal eye field results in the eyes deviating to the left. So thinking about the last two clinical scenarios, both patients have a left hemiparesis, but the direction of the gaze palsy and the gaze deviation lets you localize the lesion. So in the case of the right frontal eye field lesion, the eyes were to have turned left but are right, and there's a left hemiparesis. And in the case of the right pontine lesion, the eyes were to have turned right but are deviated left, and there's a left hemiparesis. These two sites in the brain belong to different vascular territories: middle cerebral artery and vertebrobasilar artery, which are important to distinguish in the case of an ischemic stroke. The next video you'll see illustrates this.
Look to the right. Now look as far as you can to the left. Right, and as far as you can to the left.
Next, internuclear ophthalmoplegia. Why is it called that? Ophthalmoplegia is a paralysis of the eyes, and internuclear denotes the two nuclei, the sixth cranial nerve nucleus in the pons and the opposite side third cranial nerve nucleus in the midbrain, which are connected by the medial longitudinal fasciculus. So the key signs on attempted horizontal gaze are the adducting eye, controlled by the medial rectus, fails to adduct or is slow to adduct. The abducting eye, controlled by the lateral rectus, abducts fully, but there is abducting nystagmus. And the lesion is on the side of the adduction deficit because the medial longitudinal fasciculus has crossed to that side up to the third nerve nucleus. The most common causes are multiple sclerosis in young patients and stroke in older patients. Once again, our coronal diagram and eyes facing us. Here is a right medial longitudinal fasciculus lesion causing a right eye adduction palsy and left eye abducting nystagmus, or right internuclear ophthalmoplegia. So, remember that the right frontal eye field was supposed to turn both eyes to the left by signaling the left horizontal gaze center, left sixth nerve, left lateral rectus muscle, and via the right medial longitudinal fasciculus, the third nerve nucleus, the third cranial nerve, and the right medial rectus muscle. But in this case, the red X marks a lesion of the right medial longitudinal fasciculus. So, on looking to the left, the right eye cannot adduct. And this is a case of disconjugate gaze. The eyes normally are conjugately moving together to the left, but in this case, because of that medial longitudinal fasciculus lesion, the right eye cannot adduct. Here is an example on an MRI scan with an axial view. At the top, you see parts of the frontal lobes. In the middle, parts of the temporal lobes. Just below the middle, in the midline, is the gray pons. And below that white area is the fourth ventricle, and around that, the cerebellum. So the white arrow is pointing to a white area in the right side of the pons where the right medial longitudinal fasciculus resides. And that is a lesion which affects it, creating a right internuclear ophthalmoplegia. This video example is a young patient with multiple sclerosis. His lesion of the right medial longitudinal fasciculus means that there is a right internuclear ophthalmoplegia. The right eye cannot adduct normally. The left eye abducts fully, but there is abducting nystagmus as it tries hard to get over it. The next video is another example, this time a left medial longitudinal fasciculus lesion causing a left internuclear ophthalmoplegia in an older patient whose lesion is not due to multiple sclerosis like the younger one, but to a stroke.
Okay. Look at my finger. That's a conjugate movement. Look at the camera. Finger, camera. Finger, camera. And camera. White light, camera.
The learning objectives. So you should be able to, 1, describe how horizontal gaze is controlled by the brain. 2, recognize the localizing value of gaze palsy and gaze deviation in stroke. 3, recognize the clinical signs of internuclear ophthalmoplegia, its localization, and the common causes. Thank you.